Cancer is the second leading cause of death among women in the U.S., but recent studies have shown a sharp decline in cancer screenings since 2020. In fact, according to the CDC, screenings for cervical cancer were down 84%. I'm Laura Wheatholder. I'm a registered nurse and community outreach coordinator with Blessings Health System. I'm joined today by Dr. Clark Andelin and nurse practitioner Leah Heming to talk about cervical cancer and why screenings are so important. Thank you both for joining us today. Can you start by introducing yourselves? Leah, if you'd like to go first.
Sure. Thank you for having me. My name is Leah Heming. I'm a nurse practitioner at the Blessing Cancer Center. I've been with the health system for almost 24 years and in the Cancer Center since we opened our office in 2017.
And Dr. Andelin?
Sorry.
That's okay.
I'm Clark Andelin. I'm an OBGYN with Blessing, and I've been here for about 3 years. I also want to introduce Max Lanham. He's a PA student. He's going to be finishing up here in just a couple of months. He's been working with us for the last week or so, and he's joining us as well. He's in school at the medical school in Kansas City.
Well, thanks for joining us today as well, Max. So we'll get started here. Throughout our conversation while we're live, you can add questions in the chat box and we'll get those answered. First of all, who needs to be concerned about cervical cancer? All women, or are some women more at risk?
So that's a great question. Everyone needs to be concerned with cervical cancer. Children, parents, grandparents, everyone should be concerned about cancer because it doesn't just affect the patient, it affects everyone involved with the patient. But more specifically, anyone born with a cervix is at risk of cervical cancer, and that includes those individuals who now identify as male but were still born with a cervix. So what I would like to discuss is taking it back to the basics as what is the cervix? And so when you understand what the body part is, you understand the mechanisms of how it works and how your chances of cancer can increase. But the cervix is the lower narrow end of the uterus that forms a canal or like a tube between the uterus and the vagina. And the vagina is the internal canal and the uterus is the womb where the fetus develops, and the cervix is a small donut-shaped opening that connects the vagina to the uterus. The purpose of the cervix is to help facilitate pregnancy. It helps clean the vagina by creating discharge, and then it grows a mucus plug when you're pregnant, when women are pregnant. But the mucus plug that's created by the cervix is the opening closest to the vagina. It keeps all of the bacteria away from the growing baby. The cervix is small and it expands when just to let discharge out, menstrual blood or sperm pass through. And then the opening expands large enough during childbirth. But as previously mentioned, anyone born with a cervix is at risk of developing cervical cancer. Anyone that's been infected with HIV, anyone that smokes or is heavily exposed to secondhand smoke, or have had multiple sex partners, or have had sex with anyone that's at high risk, as well as anybody that's been diagnosed with chlamydia.
So basically, it's a disease that everyone should be concerned with if, as you said, if they were born with the cervix. Now, according to the CDC, cervical cancer rates are highest among women ages 35 to 49. And that's fairly young when you talk about cancer. Is there something that makes individuals in that age range more at risk?
Yes, that's a great question. The human papillomavirus is the most common sexually transmitted infection in the world, and that's typically what people think of when they think of cervical cancer is HPV, because they go hand in hand. In 2018 alone, there were about 43 million HPV infections, and many individuals in their late teens and early 20s. Most people become infected with HPV at some point in their lives, but our immune system does their jobs and gets rid of the infection, with most infections resolving within 2 years without causing any health concerns or symptoms. But HPV infection can lie dormant for decades without ever showing signs or symptoms. So cervical cancer is frequently diagnosed in women, like you said, in those individuals born female, the ages 35 to 45, with an average age being diagnosed at 50, and it rarely develops in women, cervical cancer related to HPV, in women younger than 20. But The American Cancer Society has a phenomenal website and endless supply of resources. It even states on their website that many older women don't realize that they're at risk of developing cervical cancer as they age. But the virus, like I said, can lie dormant for so many years, decades even, and then for whatever reason that we don't clearly understand, either your immune system is busy, or it's busy with another virus, or it's weakened from medications or cancers or to other diseases. But when the immune system is not doing its job or up to par, the virus can become active and cause inflammation, and eventually that leads to cancer.
Okay, well, that's really good information there, and I appreciate you kind of providing that background. As with most diseases, there are what we call modifiable and non-modifiable risk factors for cervical cancer. Dr. Andelin, can you talk a little bit about, start by talking about those non-modifiable risk factors, things that we can't change. We already touched on, being born with the cervix, and then also kind of expand into modifiable risk factors for cervical cancer.
Right. So the main thing with that, there's certainly the modifiable risk factors. As Leah Heming said, most women will get HPV at some point during their lifetime. Obviously, risk factors would be having sex with someone who, as was mentioned, is a higher risk history, including numerous sex partners. Smoking is a modifiable risk factor. People don't really talk about that maybe enough. It's a good opportunity when you're talking with patients about all the bad things that smoking does. Another one is it independently increases risk, modifies the risk for cervical cancer. So talking to people about smoking, that's another thing that you can bring up as some fodder. It's not just lung problems or gastrointestinal things. It's also the cervix, the bladder, other things. So other things, women who take birth control pills have a higher risk. Part of that, sometimes I think if you're doing an exam on a woman and you see, sometimes Max and I were talking about this earlier, where you should be comfortable recognizing what normal is and then having an idea of what's not normal. So the more normal exams that you see, the more comfortable you'll be with recognizing something that's abnormal. And one of the things that happens is when a woman takes birth control pills, there's the squamous cells on the outside of the cervix, and then there's the columnar cells on the inside of the cervix. And as when women take birth control pills, there's more of a prominence, and that's the transition zone between those two cellular types is the transformation zone. That transformation zone is often hidden where you can't see it, and when it's held up inside of the cervix, when a woman uses birth control pills, it can display that like a flower opening. It's a prominent ectropion. Because of that, the HPV infection is more likely to be acquired. Also, chlamydia. Chlamydia loves to inhabit those columnar cells inside of the cervix. And one of the reasons we swab inside of the cervix, particularly, is the best place to diagnose chlamydia is because that's where it loves to inhabit. So, of course, the main thing to think about: smoking and sexual encounters are the main things with modifiable risk factors. And then certainly getting the HPV vaccine. We'll talk about that numerous times throughout this segment. The importance and the promise of the HPV vaccine, which selects for the highest risk types of HPV, like 16 and 18, especially, that causes over half of cervical cancer cases. That certainly has a tremendous potential for global morbidity and mortality, cervical cancer, and other HPV-related cancers.
So with modifiable risk factors, we're talking about sexual activity and smoking. Specifically with sexual activity, I guess, what is the takeaway for individuals with that? Is it, using condoms, or is it, what is the takeaway for women when it comes to cervical cancer risk and the connection with sexual activity?
That's a great question. It has more to do with sexual contact history. So condoms are not super effective at preventing HPV vaccine or HPV infection. So as Leah Heming mentioned, it's the most common sexually transmitted infection in the world. And unfortunately, the condom, which is always recommended, especially obviously with high risk or higher risk sexual encounters, condoms aren't that great at preventing the infection. Okay. So it can be from genital contact or moisture of secretions surrounding the genitals that can also initiate that transmission.
And the virus can shed. So even the area around the base of the penis, I mean, that is still not protected by a condom. And so there's viral shedding. That's why the Gardasil is so important. And it's super important to give it before the person has ever been exposed to the HPV virus.
And I would imagine then it's also important to know history and know a little bit about your partner then probably as well. Would you say that's true?
It's so common. I generally don't like to talk with women and give them the idea that they can zero in on who was the person who gave them the virus. As was mentioned previously, it can lay dormant for a really long time. And so, for example, if a woman has had normal pap tests and all of a sudden she has an abnormal pap test and she's been married for 20 years and it's year 8 of her marriage, or she's been married for 8 years, and then all of a sudden she has high risk HPV, it isn't necessarily that you need to go home and have a conversation with him about, like it would be if she acquired trichomonas. That's a completely different thing. You can be very sure on trichomonal exposure, but with the viruses, it's much more difficult. And so okay. I generally query too much about that. Okay. How other people feel. So sexual history is important as part of an exam, but I don't know if that answered your question.
It did. So I think it's more just remembering that HPV can be dormant. You could have had it, you can have it, and it can lead to this increased risk for cervical cancer. So as you
have it already.
Yeah. And so as you said, that's where that Gardasil, the HPV vaccine, that adds that emphasis to that, the importance of getting that.
Mm-hmm. Say one other thing. We talk about the prime age is between age 36 and 50. The HPV infection, from the time of infection to invasive cervical cancer, takes on average about 10 years, maybe 15 years. So it takes a while for that to happen. What we commonly see is women who are in their childbearing years come in for exams. They get pap testing on a more regular basis. There's a big problem with loss to follow-up after pregnancy. When you're in your 30s and 40s and you're feeling good and nothing's really bothering you, and so you might just not go back to it for any kind of annual checkup. The cases for cervical cancer I see the most classically is that exact thing. Someone has been lost to follow-up. They don't come back for 15 years, and then all of a sudden they have those symptoms of intermenstrual spotting, postcoital bleeding, and things like that. And then that's the main person. And I think that's a big reason why that particular cohort is the greatest, is the most common to present with cervical cancer, because of that lag time between exams. And so that's where, again, modifiable risk factors, pap testing and HPV testing are massive. I mean, I tell women all the time who are freaked out about if they have an abnormal pap test or we're doing a colposcopy or something, I say, I have never seen anyone get invasive cervical cancer who is getting the regularly prescribed screening tests. It's a massive success in cancer prevention.
So, and you've kind of touched on what I wanted to talk about with my next question. And as I mentioned earlier, we discussed that cervical cancer screenings in particular, as well as other cancers, dramatically decreased since the start of 2020, whether it be because, fear over COVID or just people, not remembering to get their regular screenings. You talked about why it's so important to get those screenings to reverse that trend. But can you talk about how frequently people should be getting screened? Because, even what I read, it's, if you've had, do you get screened every year? Do you need it every 3 years? What is the recommendation that you tell patients?
Max is on the spot.
Sure, yeah, I can take over.
Go for
here.
it.
So The current recommendations, there are a couple different bodies that have different recommendations. One of them is the United States Preventative Task Force. First of all, both bodies do agree that no one under the age of 21 really needs to be getting screened. It's very unlikely for cervical cancer to present in that age group, first of all. Secondly, so we tend to start at 21 with Pap screening via cytology every 3 years, and that's what the United States Preventative Task Force does recommend. The American Cancer Society recommends starting at age 25 with HPV testing alone, and then doing that every 5 years until 65 years of age. Once you hit 30 years of age, you have a little bit more options that open up. And it's either continue that Pap testing every 3 years, as long as there are no negative or no abnormal results, or you can do co-testing with HPV and Pap once every 5 years until 65 years of age. And then currently, they're both recommending that at the 65-year mark, assuming that you've had negative tests leading up to that point, that's an appropriate time to stop, but the data is pretty limited there, and so we may see that date change as we go forward as well.
I want to add something. Go ahead, sorry.
No, you please go. I'll follow up with my question when you're done.
Something from a practical standpoint, if you're thinking, should I do, say you have a 33-year-old woman who comes to see you, should you do cytology alone or should you do co-testing? I think individualizing it there's a good opportunity for individualizing it. There's some women who are really good about coming in, and there are some women who will say, I want a Pap test as often as I possibly can have one. And certainly for those women, the cytology route makes more sense. And also those women who are more likely to be lost to follow-up, if you're not seeing them very often, then by all means, over the age of 30, do HPV co-testing. Don't just do cytology alone, because if they're not likely to come back for a while, that the awareness of that infection can really help to hang on to them rather than getting the more limited information from the cytology alone. That makes sense.
So the bottom line for a patient like me, I'm in the age range that we've mentioned there. How often do I need to be seen? How often should I go to see my doctor, and how often should I be getting the Pap screening then? I'm in that 35 to 40 range.
Every year, regardless, because there are things that you can talk about that can reduce risks regardless of if it's Pap screening. But at minimum for Paps, every 3 years, and then possibly every 5 years if you're doing the co-testing as well.
And I think maybe the distinction that maybe some people don't understand is there's a difference between the pelvic exam and then the Pap smear. Is that correct? And maybe that's where there's some confusion. The pelvic exam should happen more frequently. Is that correct?
Yeah, so that's a really great point. Especially patients often don't know if you did a Pap test or if you did a pelvic exam alone and just looked at the cervix. So yeah, that's a really critical thing. So if you're asking women about their history, like when was your last Pap test, they might think that you just mean when was your last pelvic exam. And so, yeah, certainly, as was said, that the Pap test certainly isn't the only part of that annual exam that can be really critical for women. It could be domestic violence, it could be alcoholism, it could be depression, lots of other things. And sometimes the Pap test kind of is felt to be the crown jewel of what it's all about. That's the only thing that you're doing at an annual exam is getting a Pap test. And so we still recommend annual screening. And I always look at the cervix too. I would say, well, I'm going to look at it because the other thing is part of screening. If you see as we talked about before, you look at a whole bunch of cervices, then you get a really good idea of what normal is. And then when you see something, if you see something that looks abnormal, the best thing to do is biopsy it. If something looks abnormal, you don't just, if someone has a big fungating mass on their cervix, you don't just Pap it. You can Pap it as well, but you should take a biopsy. And I think that's something that sometimes is lost in those guidelines as we're thinking about just Pap testing. There are some nuances to that where
Sure.
a biopsy should be done.
Perfect. Now, Leah, as we talk about cancer and perhaps HPV, we talked about maybe that virus is going to lay dormant, but with cervical cancer in particular, are there signs and symptoms that a person should be aware of related to cervical cancer? What should they be looking for if they're concerned?
Yeah, that's a great question. As with often many cancers, depending on the stage, so whenever someone presents with cancer, it's kind of like a detective work. We stage them. It's putting all the pieces of the puzzle together. In the very beginning, if it's an early stage, there may be no signs or symptoms, which is again why Dr. Andelin mentioned the importance of screening, because he can detect some of those early changes in the tissue that are maybe considered high grade, meaning the tissue doesn't really look like the original tissue, or doesn't replicate that way. But some of the later, like mid to higher stages, some of the patients can present with spotting between their menstrual cycles, or menstrual bleeding that is longer or heavier than anything that changes from what your normal is. Bleeding after intercourse, after douching, after a pelvic exam, or some of the side effects, increased vaginal discharge, pain with intercourse, vaginal bleeding after you've been through menopause, kind of after you're done with your menstrual cycle and then you start bleeding again, or unexplained or persistent pelvic pain. Some of the more advanced cervical cancers that typically come to us at the cancer center, those patients can present with abdominal bloating, unexplained weight loss. Those are all kind of big red flags for us here. Vomiting large amounts, constipation, abdominal bloating, distension, just overall like a vague not feeling well.
I think it's important too with that, as Leah Heming was saying, that those are things that are often symptoms in a more advanced stage of the disease. The early stage, which is obviously when we want to find these things and prevent it, often there's no symptoms. So oftentimes when you get that unexplained bleeding or postcoital bleeding, it's often, those women are often at a more advanced stage. And again, you can tell a lot based upon just from the history of when was your last Pap test. That's really important. And as was said, finding out with those symptoms, unexplained bleeding problems, as was mentioned as well in the postmenopausal period, we always want to assess that to make sure it's not an endometrial or a cervical cancer.
And so knowing that this can be maybe something that you're not noticing big red flags, it really stresses the importance of having those regular screenings. So big takeaway on that one, because you might not know until it's advanced, and there's certainly ways to detect it early. So screenings are important. Now, once a person is diagnosed with cervical cancer, what are their treatment options? What does a person maybe, what can they expect?
You want to go or you want me to go?
I'll start just because my portion.
You can go with early stage and I'll talk about late stage
disease. So yeah, the bottom line is if there's a possibility of resecting the whole cancer, surgical treatment can be performed and can be curative. Once the cancer starts to grow, and generally it'll grow further up from the cervix and further down from the cervix into the vagina. It'll do lymphovascular space invasion, and it'll start growing outwards towards the pelvic sidewalls. Once you get especially the cancer growing out to the pelvic sidewalls, where you can feel on exam that there's no mobility to the uterus. Obviously, the uterus, there should be mobility. And once you have that parametrial disease, then it upstages it, and it goes to radiation and possibly chemotherapy as well.
So I'll just add on to that. As he said, anytime you can cut cancer out, it's out of the body. Once it has invaded, as he's mentioned, it kind of creeps like this. It goes through the different layers or to adjacent organs. Once it leaves that cervical area and goes deeper, then sometimes surgery is not able to get all of it. With more advanced stages, as he mentioned, surgery is an option, radiation is an option. Sometimes if the cancer has spread beyond the cervix and has gone to adjacent organs, you can do a debulking surgery, which kind of minimizes it, but it's not a curative intent. We can do chemotherapy, we can now do immune therapy, just progressing, depending on the severity of the stage. The higher the stage, kind of the more long-term treatment, and where cure is not necessarily an option.
So as with, I think we talk about this a lot when we do these Q&As and these lunch and learns, is it's always an individualized care plan. So, you know, the diagnosis might be the same in two people, but the treatment plan might be completely different.
Yeah.
Well, we've covered a lot of information today, both on cervical cancer screening, cervical cancer prevention. Is there anything that either of you would like to add that we didn't touch on?
I think my takeaway point for most everything in the realm of cancer is the easiest way to treat it is to prevent it. I mean, Dr. Andelin has mentioned how important Gardasil is. It really is. And the factor with Gardasil is the HPV immunization. If you can get it to the patient before they start having intercourse, that is when the vaccine will have its best bet at protecting you against HPV. Most seniors in high school, by the time they graduate, have had 5 sexual partners already. So, you know, getting those vaccines, talking to the parents of the children when they're in the age groups of 9, 10, 11, before they've ever been exposed to the virus is the best.
And you mentioned the vaccine. I want to remind people that even though cervical cancers, for people who were born with the cervix, both male and females can get the HPV vaccine, correct?
Yes.
Dr. Andelin, is there anything that you would like to add today?
I agree with everything Leah Heming said. The one thing I would say is part of the vaccine, the candidates for the vaccine, it was recently changed so that recommendation could include women past or men past the age of 26 up through the age of 45. And especially that's an individualized scenario. Of course, before it was only approved for individuals up through the age of 26. But now with it past that, you can think of a patient who might fall into that category. Maybe someone who was married, they had one sexual partner, just their partner, they got divorced at age 30, you know, they would still be a good candidate for the HPV vaccine because they could still be HPV naive at that point. And again, there's over 100 different subtypes of HPV. The vaccine doesn't cover all of them, but it does cover the highest risk. And so prevention is the best.
Well, thank you both so much for joining us today. And I think the major takeaway is, one, make sure you're following the screening guidelines, talk to your doctor. And you know, if you think that you fall into one of these categories where maybe you're eligible for the HPV vaccine, again, talk to your doctor because that could be a major preventative tool for you when it comes to cervical cancer. So thank you again for joining us. You can find more information on cervical cancer as well as Dr. Andelin and nurse practitioner Leah Heming on our website, blessinghealth.org. Thank you.
Thank you.